cardiology department. So safer and better tolerated due to significant improvements in the composition, and still associated with certain risks. And adverse effects can vary from minor to rare, severe life-threatening situations. It is essential to be prepared to manage the entire spectrum of the adverse events. Important to identify which media has the best risk versus clinical benefit profile. Can you change this? So what are the properties of ideal contrast agent is? It's water solubility, chemical and heat stability, and it should be biologically inert, low viscosity, lower or same osmolarity as human serum, and selective excretion, and it should be safe and affordable cost. So coming to the evolution and types of contrast media, it's running. So in the older generation contrast, it has 5 to 8 times higher osmolarity than blood. They are the ionic monomers. Then came the 2 to 3 folds more osmolarity compared to the blood. There's non-ionic monomers. Then came the ionic dimers and non-ionic monomers. Sorry. So you can see the types of available contrast media. The older ones are ionic, and newer ones what we are using now are non-ionic monomers and dimers. So non-ionic dimers, you can see the osmolarity is high, 600 to 850, where compared to the dimer it is isoosmolar, almost 280 milliosmolar as compared to the blood. So coming to the definition of contrast-induced nephropathy, it is an acute renal failure within 48. What's going on? So acute renal failure within 48 hours of exposure to intravascular radiographic contrast material, and it should not attribute to other causes of renal failure. And biochemical values are an increase in serum creatinine levels between 25 to 50% from the baseline, or absolute values 0.5 to 1 milligram per deciliter from the baseline. Coming to the pathophysiology of CIN, when contrast media goes in, like if it is hyperosmolar, it causes red blood cell aggregation, thereby decreasing the blood flow, and also it activates vasoactive mediators, and cortical and medullary vasoconstriction will be there, and due to high viscosity, renal tubular viscosity increases, renovascular resistance increases, and thereby it decreases the glomerular filtration rate, and it leads to acute kidney injury. When in chronic kidney disease, if they are exposed to contrast media, contrast enters the renal vasculature, and endothelium independent transient vasodilation will be there. It lasts for minutes, and which leads to adenosine release from the macula densa, endothelium release, and dysregulation of the prostaglandin will be occur, and which leads to sustained intravascular vasoconstriction, which lasts for hours. Again, which give us to the prolonged contrast transit time in the kidneys, and increase contrast exposure to renal tubular cells, and also causes medullary hypoxemia, which leads to which gives us to the acute kidney injury due to the direct cellular injury, oxidative stress, inflammation, and also ischemic injury of the cells. Coming to the burden of the CIN, incidence is 1 to 6% in the general population. And coming to the high risk population, more than 50% in patients with diabetes and pre-existing renal impairment. Incidence in patient with diabetes, a total of 9 to 40% in patient with mild to moderate kidney disease, and a total of 50 to 90% in those with severe chronic renal insufficiency. And it is CIN is the third most common cause of acute renal failure in hospitalized patients. So you can see the diagram here, increased mortality associated with CIN when compared to the no CIN. So coming to the risk factors for CIN, Those are divided into two: patient-related risk factors and procedure-related risk factors. So in patient-related risk factors is if renal insufficiency, patient with diabetes mellitus with renal insufficiency, age if more than 75 years, volume depletion, hypotension, low cardiac output, class 4 congestive heart failure, if patient is using other nephrotoxic drugs, a renal transplant patient, and hypoalbuminemia. Coming to the procedure related risk factors, multiple contrast media injection within 72 hours of period, intraarterial injection site, high volume of contrast media, and high osmolality of contrast media. So impaired renal function, altered renal oxygen supply, intensified renal parenchymal hypoxemia, then this causes enhanced renal reactive oxygen species formations, and tubular and vascular endothelial cell injuries, and reduced GFR, which leads to CAN. So there is a diagram showing both contrast media and diabetes affect the dilatation of the renal vasculature. When it is without contrast media, its dilated vessels are there. You can see from right to left. With contrast media, with diabetes, renal vasculature is constricted. You can see here correlation of diabetes and renal function as a risk factor for CIN. What are the clinical features? So they are having mostly divided into two. One is like benign condition, a non-oliguric asymptomatic transient decline in renal function. Serum creatinine level begins to rise within 24 hours of contrast administration and peaks within 3 to 5 days and returns to baseline within 10 to 14 days. Another debilitating condition is oliguric acute renal failure requiring hemodialysis, oliguria within 24 hours of contrast administration and persisting for 2 to 5 days. Serum creatinine levels peaks within 5 to 10 days and return to baseline within 14 to 21 days after dialysis and other treatment. Morbidity and mortality rates are significantly higher in patients with oliguric acute renal failure. So coming to the treatment part, so monitoring serum electrolytes levels and appropriate nutritional support and strict recording for input and output chart, and dietary restriction of potassium and potassium binding reagents and other hyperkalemia treatment, correction of acidosis and oral sodium bicarbonate, and temporary hemodialysis or permanent dialysis if severe cases, and permanent kidney dialysis and transplantation required in some patients. So consensus guidelines for prevention of CIN is: general guidelines, avoid dehydration, consider alternate imaging studies if not requiring which is not requiring iodinated contrast medium, minimize contrast medium, avoid repeat iodinated contrast studies within 48 hours, and use low or isoosmolar contrast medium. So two most important factors are avoid dehydration and selection of the contrast media. Mostly use, if any risk factors, use isoosmolar contrast media. So selection of the contrast media, increase in incidence of CKD and diabetes is likely to make CIN as a significant challenge for treating physicians. So identifying the risk factors and incorporating appropriate prevention measures is crucial. So you can see here the isoosmolar contrast media, if you use, there is a less incidence of CIN. You can see again lower incidence of CIN with isoosmolar when compared to the low osmolar contrast media. So you can see there is a Meher risk factor scoring system. Here scores are given, and if any risk factors are there, diabetes or any chronic kidney disease, you should use isoosmolar contrast media when compared to low osmolar. Okay, so a proportional decrease in toxicity as osmolarity reaches the serum concentration, direct relationship between CIN and mortality. So important factors are prevention of CIN, avoiding dehydration, and selection of contrast media. So use of isoosmolar contrast media, lower prevalence of CIN when compared to the other things. Thank you.
Thank you, Dr. Prakash, because we are running short of time. So next speaker is Dr. Nitin. He will talk about radiation protection in cardiology. I think can be possible if you leave the cardiology as a only practice as a non-intervention cardiology, or you start doing robotic PCI. Let's see.
Good afternoon, my respected teachers and colleagues. So the most important topic. So that's obvious is that air, thrombus and calcium are the obvious enemies for any interventional cardiologist. But the hidden enemy is radiation. So though it's a small hit each time, it's a cumulative exposure over time. So because of which usually we face problems. And to that, to reduce that exposure, the principle that is advised by ICRP, that is the International Committee for Radiation Protection, is as low as reasonably achievable radiation dose. So how to achieve it, just I will tell. So you can see the exposure, amount of radiation exposure with our routine cardiac interventions. So 1 per PCI is equal to 750 chest X-rays, and then CTO it's almost 4000 chest X-rays. So that is the amount of radiation the patient will be exposed. Though we have shields, even over a period of time, it's a huge amount. Now coming to the basics of radiation, once the radiation beam, the energy is released from the energy source, 10 to 20% is scattered, that is we are exposed, and then almost 70% will be absorbed by the patient, and only 10% will penetrate and that will form the image. So that is the amount of radiation, and then the radiation we are exposed as an interventional cardiologist are, that is a leakage radiation and scattered radiation. So that this is measured by different methods, that is a biological effect that is measured by sieverts, and then absorbed dose that is in gray. So usually on the monitor we will see these parameters while doing a procedure, that is the fluoroscopy time, and then total air karma at interventional reference point, and then air karma area product. These are the measurements usually we will get on the real time monitor. We have to see for that. So but previously they used to take only fluoroscopy time as a measure, but that is a fallacy. So even though you are 90% of PCI you are doing fluoro, but it occupies only 40% of radiation, but 60% is because of cine. So because cine is equal to 10 to 15 times radiation than fluoroscopy. So but that's why fluoroscopy time is not ideal measure, but you have to measure total air karma at interventional reference point. These are the two measurements you can see, that is dose area product or karma area product, that is the total amount of radiation delivered by energy source. And then second thing is air karma at reference point. Reference point is 15 centimeters from the patient, that is called interventional reference point, that is the dose to which patient is exposed. These are the 2 points usually you will get in the monitor, but usually you will ignore it. What are the adverse effects of radiation? They are deterministic effect and stochastic effect. Deterministic effect means there is a threshold level. So with increased radiation, the adversity of increase, that's adverse reactions will increase. Usually they are damage to the skin, damage to the lens, and then gonadal injuries. And then stochastic effect means there is no dose relationship, that by probably they will get, that is because of DNA change. So usually that is interventional cardiologists are 3 times more prone to develop a left side brain tumors, and 7 times they are prone for a cataracts, especially posterior subcapsular cataracts. So then how to achieve and what precautions we have to take in our day-to-day practice as advised by ICRP guidelines, that is called ALARA approach, as low as reasonably achievable radiation dose. The main 3 things are keep the distance from the radiation source and reduce the time of exposure and use the preventive shield, that is protective shields. So the radiation follows inverse square law. As the distance increases, so it reduces by square. That is the radiation exposure will come down by inverse square. So we have to be distant from the radiation source, especially radial interventions. The patient, there will be more radiation exposure compared to the femoral interventions. For that what we can do is extension manifolds you can use. Each centimeter is also important. Even if you keep 5 centimeters away from the radiation source, it's a significant radiation effect. And then don't lean onto the table. So you should be away from the patient, away from the table, and especially while taking a cine, we will tend to move forward to see on the monitor, but don't do that. Even you have to be straight or else come backwards, and then next you can review anyway the cine image. So, and then coming to the subject image distance. So whenever the table height should be high enough, so that the patient will be away from the radiation source. So this increases the patient, so otherwise as the distance comes down, the radiation exposure to the patient will increase. And then image intensifier should be close to the patient. So because that will reduce the scatter radiation that is useful for the operator. And coming to the frame rate of fluoroscopy, usually we will do fluoroscopy at 15 frames per second, but just by reducing the frame rate to 7.5, so you can reduce the radiation dose by 67%. So most of the times fluoro we should be happy. So always we should balance between image quality versus radiation dose. Most of the time 7.5 frame rates should be okay, but you can reduce the radiation by 67%. And then coming to the magnification. So as the magnification increases, radiation dose will increase. So compared to the if you non-mag to single mag, so radiation is increased by almost from 0.3 to 0.6, that is double. And then if you do a double mag, it's almost 4 times the radiation. So most of the machines, newer machines will have a digital magnification. So you can take a cine and then you can magnify digitally without increasing the radiation exposure. And then always we have to use a collimation. So collimation will reduce the overall radiation burden to the patient as well as the operator. And then regarding the angulations, don't use steep angulations excessively. So because in steep angulation what happens is the radiation beam has to pass through all the organs. So that is the path it takes is longer. So the image quality will come down. Automatically the machine will give to compensate that, machine will increase the radiation exposure. So by that the overall radiation exposure to the patient as well as the operator will increase. And second thing is, especially in elevocranial and lateral angulations, so the image source will be close to the operator. So that's why, so it's better to avoid the steep angulations. And then whenever you are using a left lateral or left elevocranial position, always use a shield. So without a shield, either it's a table mounted or ceiling mounted, whatever portable shield, so keep a shield and then take and then minimize the angulations. And then don't do a procedure in the same angulation for a long time, because it increases the patient radiation dose to one focal point, that causes skin problems. So you have to distribute the radiation dose. At least once in 30 minutes you have to change the angulation. Especially it holds true for a CTOs. And most of the machines will have fluorosave option. You can use the fluorosave option or last image hold option, and don't do long cines except for if you want to see for collaterals in a total occlusion or for a slow flow. Otherwise try to limit the cine acquisition, because 10 to 20 times more radiation compared to the fluoro. And then always check on the monitor regarding the radiation dosages. So these dosages are fluoro time as well as this radiation exposure will be displayed. So one radiation technician has to see at the monitor and they have to notify. So once fluoro time is 30 minutes, first you have to get a first notification. And then pKa, that is the product of the air karma plus the area, that is 300, or focal air karma is 3. First, we have to get a first notification, and then again second notification, and a third notification, that is a substantial dose, radiation dose limits, then patient is at risk. So then we have to use the protection shields. Usually we will wear aprons, but it should be snugly fit and with a frontal overlap. It is double, and all types of thyroid collars and leaded gloves, leaded eyeglasses. You would use maximum amount of shields. And then if you, to avoid orthopedic problems, even you have that is ceiling mounted radiation protection device is there, that is called zero gravity radiation protection system.
Yeah.
But only thing is, it is cumbersome. Whenever you change the angulation, we have to change the whole system. And then there are now future is robot cath labs, but the thing is, presently for most complex cases, still it's used only for simple cases and simple lesions. We should wear badges, and then ideally we have to wear 2 badges. One thing is behind the apron, that is at the waist level, and one more thing is at the collar, that is to measure the radiation exposure to the eyes. So because nowadays they are focusing more on eyes. So because previously the maximum allowable radiation dose eyes was 150, but now changed it to 20, but is 7 times. So because there is almost 7 times increase in the cataracts in interventional cardiologist, so that's why they advise one more badge should be wear above, that is out of the radiation shields at the level of collar. And then and you have to measure your dose. And the thing is, usually you will take once in a quarter or once in a year. But real-time monitoring, nowadays there are some devices are available. You can measure your real-time dose, radiation dose exposure, and you can monitor whenever that is more, you can change your position whenever you are receiving more radiation. And then following all these principles, you can reduce your radiation exposure by 40%. So just wearing a aprons is not enough. You have to take all these precautions so that you can reduce your radiation exposure, and you should be careful regarding your life. Thank you.
Very good presentation, Dr. Nitin. Can I ask one question? According to latest ESC guidelines, it is radial route is more preferable than femoral. But at the same time, 2017 March ACC AHA guidelines told the radiation to this thorax is more with the radial. Which do you follow?
Usually
guidelines. Unfortunately.
No, radial route it's exposes to more radiation exposure. But the thing is, you should keep a distance. You can use a extension manifolds. And second thing, you can use even pelvic shields to the patient, and then you can use the leaded gloves, especially whenever you are you're doing a echo guided interventions like endomyocardial biopsy. Whenever your hands in radiation under radiation exposure, you can use leaded gloves. But still, yes, radial is preferable.
Thank you. It's a nice presentation. Actually, I had cataracts in 1996, operated. I'm waiting for the brain tumor. Thank you.
Sir, one more thing is as radial interventions, CTOs are more radiation, no? So radio pads are available, sir, now. We can keep on the femoral site and we can use. They will absorb the radiation and less amount of radiation to the patient. What I observed in with the CTO operators.
The next speaker is Dr. Mukesh. He will be speaking on the newer drugs in cardiology.
Chairperson.
While Dr. Mukesh is getting ready, CTO, when you do an unnecessary procedure, that is the price you pay.
So I'm going away from the interventions and now back to drugs. Thank you, CSI, Dr. Sridhar, for giving me this opportunity. Chairpersons, respected seniors, colleagues and friends. So my talk is on drug therapy in the new 3 drugs which were given was ergotamine, cangrelor and PCSK9 inhibitors. Just a brief case study from just a created 50-year-old gentleman with unstable angina on low molecular heparin and other conventional anti-anginal drugs. For 5 days referred to a tertiary care center for further management in view of worsening of symptoms. He is hypertensive, diabetic with high borderline creatinine, and angiogram revealed single vessel disease of RCA. Clinically had necrotic skin lesions. So there are some students over there. Can you identify the skin lesions? They're basically necrotic skin lesions. They're not ecchymotic patches, but it's the early signs of HIT. So HIT we all know, not very common, but we do come across once in a while. So this angio typically shows some thrombotic lesion there. Now the problem in this particular patient is ACS with a single vessel disease, necrotic skin lesions. There is some thrombocytopenia. So the probable diagnosis is HIT, HIT and HITS. What is the difference? So HIT is when there is antibodies, hepatitis when there is thrombocytopenia, HIT is when there is associated syndrome. So what shall we do with this patient? Either heparin shall we continue or not? Platelet transfusions, yes or no? Anticoagulations, what oral or IV? Shall we proceed with angioplasty or no? So next few minutes I would like to answer these questions. So this can't be HIT because the platelet count is not low. Is it so? So clinically when should we consider HIT? So heparin exposure, either any kind of low molecular weight or unfractionated heparin with thrombocytopenia and ongoing thrombus. So this is a criteria to say HIT whenever the thrombocytopenia is less than 1.5 or 50% drop in platelets or 30 to 50% decrease with documented thrombosis. So the timing of thrombocytopenia is important. It can be usually between 5 to 14 days, but can occur early or sometimes late also. So it is a relative rather than absolute criteria for thrombocytopenia. Platelet count may be normal sometimes because there can be the delayed manifestation. So platelet count typically drops 48 hours and then starts improving after 3 to 4 days. So platelet recovery usually starts after 4 days. So these are the diagnostic criteria whereby some scoring system is there. If the score is above 6, it is a definite hit. So what is the different temporal patterns of hit? Can be it's an early hit, typical hit, or can be sometimes even a delayed hit after 9 days. So it is a tip of an iceberg. So what we see is antibody formation starts in 3 to 60%, thrombocytopenia 1 to 3%, but thrombosis occurs only in 1%. But that carries a mortality of 30 to 50%. So these are the laboratory tests, but basically it is a clinical diagnosis. Apart from that PF4 antibodies which we shed. These are typical skin lesions which can occur in patients with hit. Now, will it go away if you just stop heparin? Not so. So it can be a thrombotic storm, can produce deep vein thrombosis, arterial thrombosis, and can lead to a lot of morbidity and mortality. If you don't treat, it could be initial, then it can progress like this, it can progress, and then it can go extensively. So what are the treatment options? Once it is diagnosed, direct thrombin inhibitors is the only drug of choice in these patients. So that is whenever the 50% platelet fall with onset within 5 to 10 days, classical hit, you should start direct thrombin inhibitors. These are typical direct thrombin inhibitors are two types. One is univalent and bivalent. Bivalent is basically bivalirudin and hirudin, and univalent is argatropin, which specifically binds to active site. So this is the difference between indirect versus direct thrombin inhibition. Argatropin inhibits directly the thrombin specific. So the problem with classical heparin is it is an indirect thrombin inhibitor and it will not completely inhibit the clot-bound thrombin. So this is the difference between heparin and, so I'm just skipping few slides because of want of time. So argatropin has a unique mechanism of action and overcomes the limitations of heparin. It's a direct thrombin inhibitor that is reversible via thrombin yielding and with a short half-life, that is 45-minute half-life. It inhibits clot-bound and circulating thrombin, inhibits thrombin-mediated platelet aggregation, and does not activate platelets. It provides predictable pharmacology and linear pharmacokinetics. So basically management of it includes discontinue and avoid all heparin, give non-heparin alternatives like argatropin, start warfarin late, test for hit antibodies, investigate for other causes, and avoid prophylactic platelet transfusions. So argatropin is an ideal anticoagulation in many ways because it binds to the active site and it is reversible, does not bind to exocytes, first introduced in Japan in 1990 for the treatment of peripheral vascular disorders. So argatropin is a DTA that binds avidly and reversibly to the catalytic sites of thrombin and that does not require other cofactors to exert its antithrombotic action. It inhibits both circulating and clot-bound thrombin while also inhibiting thrombin-mediated platelet aggregation. A rapid onset of its anticoagulation is achieved after IV administration. Short elimination half-life of argatropin ensures rapid restoration of hemostasis upon cessation of treatment. It does not bind to plasma proteins or to RBCs. So therefore, it has a predictable antithrombotic response. Argatropin is given IV and drug plasma concentration reaches in its steady state in 1 to 3 hours. There is no risk of hit or HITTS. Specific mechanism of action and favorable pharmacokinetic profile of argatropin suggests that it could be beneficial in all indications where other IV anticoagulants are used. So these are the different the specific advantages of argatropin. The dosage is usually, it can be diluted either with dextrose or normal saline. In HIT, it is 2 microgram per kg per minute administered as a continuous infusion. You have to monitor by measuring the APTT, keep it around 1.5 to 3 times. For PCI, it start bolus of 350 microgram per kg over 3 to 5 minutes and initiate continue infusion at 25 microgram per kg per minute. Dose to be adjusted as per ACT to keep it between 300 to 450. So drug transition is whenever patient is on argatropin, after 2 hours you can safely switch over to any of the oral anticoagulants, or even when they are low molecular heparin also it can be safely started after 2 hours because it's a short acting drug. This is a small study that was published when they studied effect of argatropin in elective PCA situations. So this is ARG-E4 study. Argatropin dose dependently increases coagulation parameters and compared to UFH demonstrate a superior and predictable anticoagulant effect in patients undergoing elective PCI. This is the dosage that is between 200 to 350. It adequately maintains the ACT between around 300 to 500, whereas unfractionated heparin, it is very unpredictable and the ACT can vary a lot. So this is the, usually most of the times the ACT will be in the normal range once you give the bolus and start infusion. So usually 250 to 300 micrograms is enough to maintain adequate ACT. And if required, depending on the ACT, we have to give additional 25 micrograms of bolus. So the clinical endpoints, there is no statistically significant difference, but there is a slight superiority because there is no increased risk of bleeding. But the all-cause mortality and primary endpoints, there is no difference. This is a landmark trial on argatroban anticoagulation in HIT. In HIT, there is no controversy. There is the drug of choice, and target APT, if it is maintained, 76%, 86%, it can be treated. Event reduction is 84%. Recovery of platelet count also is almost 53 to 58%. And increase in platelet count starts once you start argatroban. So the patients undergoing PCA who are at risk of it, this is the main indication. Experiments recommend use of argatroban as a substitute for heparin or low molecular heparin in patients with risk of it or undergoing PCI. In patients with thrombosis associated with HIT, prevention and treatment of thrombosis in patients with HIT. So our patient, which I discussed, is an ideal case for argatroban, but clinical situation, it is very less to see such a patient. So this is the bivalirudin which was available earlier, but latest validated sweetheart study that is published last in ESC, they have shown that there is no difference in primary endpoints between bivalirudin and heparin. But if you look at the data, MI, stent thrombosis, they were all less in patients with bivalirudin. Earlier, there is an apprehension that bivalirudin causes more stent thrombosis, but in this study, it has shown about less than conventional heparin. Whether argatroban, is it going to take over the place of bivalirudin? It has a better anticoagulant when compared to unfractionated heparin, needs more data. So to conclude, it's a novel anticoagulant, highly selective direct thrombin inhibitor, FDA approved in 2000 for HIT, 2002 for PCI, MHRK in UK also approved. I'm skipping. Next is Cangrelor. Antiplatelet therapy is a critical part of contemporary PCI. In the era of aspirin and unfractionated heparin, intravenous GP2B inhibition significantly reduced the importance of pre-procedure ischemic events, but significantly increased the risk of bleeding. ADP receptor antagonism with oral agents was also shown to reduce ischemic events in PCI, especially ACS. However, the available oral agents are limited by their relative long duration of action and bioavailability, which might be a liability. If given prior to coronary angiography and urgent emergent CABG is deemed necessary, the risk of CABG bleeding is more. In these situations where absorption may be problematic, such as with rapid times to PCI, in patients who are intubated, we need a rapid intra-IV antiplatelet drug, that is the Cangrelor. So these are the classical classification of antiplatelets that are available. This is a mechanism of action where different antiplatelet drugs act. This is the pharmacological, just to consider, half-life is just 3 to 6 minutes. So once we give IV dose for taking up a patient's primary PCI, the action starts immediately, and the offset is 60 minutes. That is ideal. Even if you want to send the patient for a CABG, the antiplatelet effect is not much. So there are few studies published regarding Cangrelor. Initially, it was compared with placebo, then it was compared with abciximab. In both, it has shown that bleeding risk is less, and primary endpoints they're slightly better when compared to abciximab. This STEP-AMI trial where Cangrelor was given in combination with the TPA half dose, it showed a better vessel patency when compared to TPA alone. These are the basically 3 important trials: Champion PCI, Champion Platform, and Champion Phonics. Just to conclude, Champion Phonics has proved that Cangrelor is much superior to clopidogrel in reducing the primary endpoints as well as the secondary endpoints like stent thrombosis. Cangrelor is an intravenous ADP receptor antagonist that is rapidly acting, potent and reversible with return of normal platelet function within an hour. Cangrelor was studied previously in 2 large trials, but Champion Phonics, it has proved that there is a significant reduction in primary and secondary endpoints. So the key secondary endpoint of stent thrombosis was also significantly reduced. The benefit was sustained throughout 30 days. There was no excess of severe bleeding and transfusions. So intravenous Cangrelor may be an attractive option across the full spectrum of PCI, including stable angina. I'll just take 2 more minutes, sir. PCSK9 inhibitors. So this is a proprotein sabutylin inhibitors. When to add these drugs to non-statin therapy? This is a JAC 2016 and ESC 2017 guidelines mentioned that adding estimab or PCSK9 monoclonal antibodies to maximally tolerated statin therapy may be cost-effective in very high and high-risk patients with ASVD and familial hypercholesterolemia. Estimab causes further 20% reduction, whereas these monoclonal antibodies cause 50% reduction of LDLC. So basic mechanism of action of PCSK9 is it increases the level of LDLC by reducing available pool of hepatic LDL receptors. In the absence of PCSK9, the LDL receptors are recycled back to plasma membrane. There is an inverse relation between PCSK9 activity levels and LDL receptors suggests that PCSK9 inhibition could have a synergistic effect with statins. So if we just look at this slide, PCSK is whenever usually the LDL particles combine with the receptor and then it combined with PCSK9 and the entire thing will get metabolized in the lysosomes. Whenever you give these inhibitors, it prevents binding of that PCSK with the LDL receptors. So more receptors will be available and they are circulated back and then more LDL is captured. So statins prevent this HMG-CoA reductase. So PCSK inhibitors ideally have a synergistic affection with statins. So there are a lot of ongoing trials going on alirocumab, evolocumab and bocozumab. And this is how the plasma levels of LDL correlates with the dosages of monoclonal antibodies. This is again the mechanism of action. I'm just skipping for want of time. So again shows that this is an important slide where whenever monoclonal antibodies were given in patients with statins, there is further reduction of 17% to 50% reduction in LDL-C. So again, they have a positive effect on non-HDL, ApoB and reduction in LPA also. They have a slight increase in HDL-C and cause a reduction in triglycerides. So they are useful in statin intolerant patients. And basically main importance is in hereditary familial hypercholesterolemia, both homozygous and heterozygous. So in both conditions, there can be LDL reduction up to 67 to 57%. So just to conclude, key takeaways: argatroban, drug of choice for HIT, and larger studies are needed for routine use in PCI. Canglar is included in 2017 ESC guidelines for selected patients to be used. PCSK9 inhibitors recommended in very high and high risk patients with ASVD and familial hypercholesterolemia. Thank you for your kind attention.
Yeah, thank you, Mukesh. It's very difficult to cover within 10 minutes, but anyhow, we are running short of time. Next speaker, Dr. Sridhar Kasturi. He will talk about Takayasu arteritis interventional approach.
Good evening, everyone. Actually, we have covered almost all topics, but Takayasu was not covered. For that sake, I included this one because we come across Takayasu very oftenly. So I wanted to show some cases where No, next one, not this one. Okay, right. Yeah, thank you. So this is a 14-year-old male. He came to me with I will go directly with the angiographic pictures. So you can see the why it's not playing, just otherwise I can go to the next and keep our same laptop. We'll go to the next topic. Shiva. No, already got delayed. Don't waste time, Shiva. Go to the next topic and no, it's not moving. Here it's not moving. Go to the next topic. Come here, I'm telling. Just to put our own laptop. It's not playing. Go to the first slide. Yeah, go to the first slide. First one. If it is playing, that's fine.
It's okay.
Go back.
Bus.
Yeah, go back. Go back.
No.
Go back. So I will only move.
This one first.
Yeah, this young boy came to us when he was referred to me. He had a long segment disease of the aortoiliac arteries, right renal artery, tightly stenosed, left renal artery totally occluded. If you see the next, see left common iliac artery totally occluded. There is a long segment infrarenal segment disease. So right renal artery tightly diseased and left kidney shrunken and non-functional. So then what we did the long stenting of the aorta iliac. That is smart nitinol 12 mm stent was implanted, self-expanding after balloon dilatations. So right renal artery was stented, and the CTO of the left common iliac artery through left femoral approach. Then it was crossed and balloon implanted. Balloon dilatation, subsequently balloon and expandable stent was implanted, Genesis stent. So this patient, like a 18-year-old boy, had infrarenal long segment of aortoiliac disease, CTO of the left common iliac artery, right renal. So total reconstruction was done and his pressures was controlled. This is 1 year follow-up CT angio. We can see a long segment aortoiliac bifurcation was created, right renal artery was stented. This is another 47-year-old male. You see the image, long segment occlusion of the aorta. So when he presented with sudden onset of paraparesis and renal failure. So when we see the aorta, very unusual presentation. So paraparesis, elevated creatinine, and he was a construction worker. So when he was referred to me, he went to many hospitals. Then when he approached, then I said we'll do for this patient. Then we took almost 4 hours to cross this long segment, almost 1 foot long segment lesion. It was crossed using various wires, thermo, all wires were tried. Finally, we could cross with the Shinobi wire. I struggled for 4 hours. Then the entire segment was stented, and you see all epic stents were implanted. This first stent, the second stent, 3 long stents were implanted, and reconstruction of the totally occluded aorta was reformed. And always I take the pre and post CT angio. This is the 1 year follow-up patient, is now completed 3 years. Now he is walking. Now he is absolutely fine, pain-free, no claudication, and he is doing very well. And this is another patient, 27-year-old patient, total occlusion of the young female, present with refractory failure. So almost we took 3 months to stabilize her. The patient was presented with severe refractory failure, steroids was given, azothioprine was given. 3 months later, initially ESR was 100, then gradually 3 months, almost we took 3 months to control the inflammation. After controlling inflammation, you can see the calcification also. This is the long segment total occlusion of the aorta just above the renal arteries, and so this is the dilatation of the totally occluded segment. We kept the 2 wires before implanting to protect the renal arteries, and these are post stenting views. This is a follow-up CT angio. You can see nicely patent aortic stent. And this is another patient where patient present with multiple aneurysm, young female CTO of the coronary artery. So huge aneurysms, multiple, and long segment lesion of the thoracic aortic arch, and multiple sacral aneurysms. And this patient also had a CTO of the LAD with renal failure. Failure was controlled, and subsequently again what we thought we'll put the stent graft for this lady, so that almost the maximum diameter of the stent aneurysm was almost 7. So this is the stent grafting of the. Now this is excluded. This is the patient was doing well, And another young lady presented with acute MI, tight stenosis of the left coronary artery. This is coronary artery stenting, left subclavian totally occluded, stenting of the left subclavian artery. And another patient underwent carotid artery stenting and vertebral artery stenting, and patient was doing well. This is another long segment lesion of the thoracic as well as abdominal aorta. The stenting of the thoracic was done, aortic was done. This lady came to us with a severe claudication, and this is very unusual case. She went to one of the tertiary care hospital, young lady, left kidney shrunken, right total, at that time right renal was normal. 6 months later she went home, presented with a severe refractory failure, and when she came to us, she was severely acidotic and creatinine was 7 and absolute anuria. 4 days we were dialyzing, but on ventilator, acidosis. Then we thought, because recent worsening maybe because of the total occlusion of the right coronary artery, we did the CT showed totally occluded both renal arteries. Then we did the right renal stenting. While doing renal artery stenting, she developed the capsular hematoma, which was covered with the peripheral coils, and she recovered very well. And another young guy presented with multiple recurrent TIA and amaurosis fugax, and this patient underwent like a common carotid artery stenting and subclavian stenting to establish the flow to the vertebral artery. So this is the total occlusion of the aorta, right common iliac artery total occluded. Again here aorta and both iliacs are reconstructed. So usually these patients are very unusual. Sometimes Takayasu arteritis can present with a life-threatening challenges like a acute coronary syndromes or bilateral total renal artery occlusions, or patient may present with total occlusion of the aorta with renal failure. In these cases, endovascular treatment is the life-saving procedure. And any time when you see the Takayasu arteritis, see whether patient is having acute inflammation phase. If the patient is having acute inflammation, see that you are adequately controlling the inflammation until the ESR comes down to below 20. I take the criteria below 20. Most of the time we will keep them on steroids and immunosuppressive therapy, and usually we take follow-up CT angios. Thank you. And that is the reason when you see the Takayasu, any like carotids, coronaries and renal artery, these are the life-threatening issues, and even it can present with aortic aneurysm, with a large aneurysm which can rupture. Thank you one and all for giving me this opportunity.
Good afternoon. I would like to thank the organizers and Dr. Sridhar Kasturi for inviting me for this lecture, respected chairpersons and dear colleagues. Today I would like to discuss the important topic, that is carotid angioplasty versus endarterectomy. As we all know that stroke is one of the leading causes of death, and the mortality from acute event is around 20%, and there is a substantial morbidity even among the survivors. Stroke could be because of hemorrhage or ischemic infarction. That could be because of embolization, thrombosis, or a low flow state. The proximal internal carotid artery and the carotid bifurcation are the most frequently involved. However, the MCA and the distal carotid artery and the carotid siphon could also be affected. And ulceration results in embolization and thrombosis. These are the common risk factors for any vascular disease: hypertension, diabetes, dyslipidemia, obesity, smoking, and family history. And the clinical syndromes involving the carotids are like, you have it, most common is the devastating stroke with a persistent disabling neurological deficit. You have non-disabling strokes, TIAs, reversible ischemic neurological deficit, and also vertebrobasilar symptoms, diplopia, dysarthria, and ataxia. So the diagnosis of carotid disease could be when the patient has symptoms, or it could be a screening of an asymptomatic patient undergoing other procedures like CABG or coronary angioplasty or peripheral procedures. Carotid bruise, I'll just skip the slide. The evaluation of carotid artery stenosis could be by various means like duplex ultrasonography, transcranial Doppler, computed tomography, or magnetic resonance imaging, or carotid angiography, which is considered the gold standard. The angiography permits evaluation of the entire carotid artery system and provides information about the plaque morphology and collateral circulation. And the risk of all neurological complications is around 4%, and the risk of serious complications is only around 1.6%. Carotid duplex ultrasound is non-invasive and safe, 94% sensitive and 85 to 99% specific. Transcranial Doppler is used in conjunction to evaluate the hemodynamic significance of the ICS stenosis and provides additional information regarding the intracranial hemodynamics. Magnetic resonance angiography produces a reproducible 3D image, and it is less operator dependent and produces an image of the artery, but however it is more expensive. Preoperative evaluation is required, and cardiac evaluation is also a must in terms of exercise stress testing or DSC or coronary catheterization, because very often the carotid and coronary artery disease coexist. CT or MRI is also required to rule out other symptoms such as subdural hematoma or a tumor. Now coming to the modalities of treatment, first I would go through the surgical modality, that is the carotid endarterectomy, which was first performed in 1954. And subsequently a large number of procedures and trials have been performed. It is through a neck incision along the sternocleidomastoid muscle, and a longitudinal arteriotomy is performed and carotid plaque is removed. Coming to the trials with carotid endarterectomy, this was a large NASET trial where around 1,200 patients were randomized, half of them to medical therapy and the rest to carotid endarterectomy. And they were also divided into two groups. One was the milder stenosis and the other were the major stenosis, 70 to 99%. And this study was prematurely terminated because of clear evidence of benefit from surgery. This shows that there is an absolute risk reduction of 17% with surgical modality. And the major or fatal ipsilateral strokes, again, absolute risk reduction of 10.6%. But these benefits were limited to patients with the higher grade of stenosis, and it was concluded that carotid endarterectomy was highly beneficial for patients with recent TIAs or non-disabling strokes with ipsilateral stenosis of 70 to 90%. And the European carotid surgery trial, again multi-center trial, around 2,500 patients. And after a 3-year follow-up, the findings were that patients with mild stenosis, there was not much of benefit. But in patients with major degree of stenosis, there was a significant reduction in the ipsilateral stroke, and the total risk of surgical death or surgical stroke or any other stroke was 12.3% as compared to 21% with medical treatment. In the European carotid surgery trial, the final results were based upon 3,000 patients, and it again showed that there was a significant benefit of carotid endarterectomy. So this is a summary of the various trials comparing the best medical therapy versus carotid endarterectomy. Most of the trials have shown that there is a significant reduction in the stroke rate in carotid endarterectomy as compared to the medical treatment. In the asymptomatic patients, you had the Casanova trial and the Mayo asymptomatic carotid endarterectomy study. They found that there was a significant incidence of myocardial infarction and TIAs in those undergoing surgery. In the Veterans Administrative Cooperative Trial, after a follow-up of almost 48 months, they found that there was a lower incidence of total endpoints in the surgery plus aspirin group as compared to only aspirin group, and there was a lower incidence of ipsilateral stroke, 4.7 versus 9.4%. The ACAS trial, which considered patients with more than 60% stenosis, they were randomized either to surgery or aspirin, and they found that after a median follow-up of nearly 3 years, the perioperative stroke or death was significantly lower in the surgical group. And a subgroup analysis revealed that carotid endarterectomy was less effective in women, perhaps because of a higher incidence of perioperative complications. The complications from surgery are ranging between 0.5 to 3%, and majority are because of the cardiac events, and the stroke rates range from 0.25 to 3%. There's also nerve injuries like the vagus and the glossopharyngeal nerve, bleeding risks, and the infection and labile blood pressure. And restenosis is around 2.6 to 10%. These are the predictors of mortality. And recommendations are that the ipsilateral symptomatic carotid stenosis is a proven indication for carotid endarterectomy. It is an acceptable but not of proven benefit in the 30 to 69% of stenosis. And asymptomatic patients with 60 to 90% are considered to have a proven indication for endarterectomy, provided that the surgical risk is less than 3% and life expectancy more than 5 years. Exclusion criteria for surgery is complete occlusion of the artery, severe comorbidities, previous stroke with dense neurological deficits, and symptomatic patients with hemorrhagic complications. Coming to the carotid stenting, which is done through a transfemoral catheter route with an inflation of the balloon, predilatation, and a stent implantation. You have to necessarily use filters to capture the embolic particles. There are various types of stents, the uniform or the tapered stents, and the various kind of filter devices to stab the distal embolization. The advantages of carotid stenting is that you can extend to more cephalad or even intracranial lesions. It is less invasive, and in patients with a hostile neck, it can be performed where surgery is contraindicated. So I'll just go through the various trials, the important trials. We'll just skip these slides. These are the initial trials in 1998 with carotid stenting. Now, this was a trial in elderly patients where they found that the incidence of major or minor strokes within 30 days was significantly higher in the stenting group as compared to the surgical group. And incidence of major stroke within 30 days was similar in the group, but minor strokes were higher in the stenting group. The other trials like the Caritas trial, a multi-center trial, but it was stopped prematurely and it was underpowered, and only 26 patients, they used the endovascular treatment with stents. In the other large randomized trials, that is a SPACE trial, a multinational center trial, and this was stopped because of lack of funding. Then you had the EVA 3S trial, which was a French multi-center trial, terminated prematurely because there was a higher rate of death or stroke in the stenting group as compared to the surgical group. The Caritas 2 trial, again, they found that the new ischemic lesions are more often in the stenting group than the endarterectomy group. And the 5-year results showed that there was a similarity in the incidence of fatal or disabling stroke between the two groups. But the cumulative risk of stroke was higher in the stenting group. And the newer CREST trial, which was a large randomized trial, 2,500 patients, the results were that they were almost similar, but the minor stroke incidence was 3.2 in the stenting group compared to 1.5 in the endarterectomy group. The incidence of MI was lower in the stenting as compared to 3.4 in the surgical group. This was a meta-analysis of various trials. These again show that overall the surgical group scores a little more over the stenting. The incidence of stroke was lower in the surgical group. This is just to show that these are the high-risk features for surgery as well as the stenting. So now the current recommendations are in asymptomatic carotid stenosis, they should be treated medically, but in patients who have a higher, more than 70% stenosis, surgery is probably preferred. And prophylactic stenting may be considered in highly selected patients with stenosis more than 60% by angiography and class 2B evidence. In the symptomatic carotid stenosis, more than 70 to 99%, carotid artery stenosis with TIA or ischemic stroke, then carotid artery endarterectomy is the recommended procedure, and depending on the age, sex, and comorbidities. And if the stenosis is less than 50%, they are not recommended. And patients with minor or TIA, it is better to perform the procedure within 2 weeks of the index event rather than delay the surgery. And stenting is indicated as an alternative for endarterectomy with average or low risk of complications. And the class evidence is 2A and level of evidence is B. It is reasonable to consider patient's age in choosing between these two procedures. And these procedures should be performed by operators with established peri-procedural and stroke mortality rates of less than 6% for symptomatic patients. And routine long-term follow-up imaging of extracranial carotid circulation with duplex ultrasonography is not recommended. And optimal medical therapy should include antiplatelet therapy, statins, and risk factor modifications. So stenting is recommended only when it is not suitable for surgical access, when there is a radiation-induced stenosis, restenosis after endarterectomy, and clinically significant comorbid conditions. These are the contraindications for stenting, where there is a visible thrombus, inability to gain vascular access, and active infection, and older age group more than 80 years. Thank you for your attention.
Thank you, sir, for your excellent presentation. Now, our next session is Sri Krishna Memorial Engi.
Now, Dr. Sastry will talk about the Indian DES and imported DES safety and efficacy of the
Same, Manavena. Change it.
One more topic included.
ఇది మొన్న ప్రెజెంట్ చేశారు.
Shastri. Shastri. BKS Shastri. BK Shastri. Yeah, BK Shastri. Okay. Good afternoon, everyone. I profusely thank Dr. Sridhar Kasturi for allowing me to present this small research work. There is some serious conflict of interest. Presently, I am the board member, director in the Relsis Medical Devices. On 13th February 2017, when the National Pharmaceutical Pricing Authority has put a ceiling on the price of the drug-eluting stents, there is a confusion because the drug-eluting stents imported ones were costing about 1.5 to 2 lakhs as per the hospital charges, whereas the Indian stents, Indian-made stents, were costing less. So when you brought everything together, there is a confusion and dismay because the imported stents are mostly well studied and established in randomized trials, whereas so much robust data is not available for the Indian stents. Now, there is limited registry data for the stents like Biomime and Yukon Choice, and there is hardly any data for other stents. So, this data is from the ongoing registry of the coronary interventions we have been doing since 2013. All coronary intervention patients without any exclusion are included in the registry. This is an all-comer registry. This has got ethics committee permission, and all patients were followed following obtaining consent for informed consent. We are presenting the minimum 1 year follow-up data for all the coronary stent implantations. The purpose of the study is to compare 1 year adverse clinical outcomes, including all-cause death, stent thrombosis, and target vessel revascularization, and compare between different stents. There is bias and confounding variables because the stent selection is often based on the patient's affordability and physician preference, and it is not a randomized control, it is an observational study. And you know, most of the time Arogyasri patients, they are given cheaper stents, and also when the patients who are very sick, you are doing in the middle of the night a primary angioplasty, when you are not sure whether the patient can afford or not, you end up putting a cheaper stent so that you will stop any kind of losses. For each patient, we have collected demographics, details of the intervention procedure, in-hospital course, post-discharge follow-up, and or by telephonic. We have excluded taxes and biovascular scaffolds, and if the same patient got more than one different brand of stent, we excluded them. The deaths were not adjudicated, hence we have taken all deaths are cardiac except one death which is obviously in a roadside accident. Then subacute thrombosis is only when the patient came to the hospital with subacute thrombosis and proof is there of coronary change, angiographic changes or ECG changes. And some of the outside hospital deaths could have been because of subacute thrombosis. And target vessel revasculation, irrespective of the stent was used, whether or not the stent is patent, if the patient underwent target vessel revasculation, that is included as target vessel failure. To start with, there are 5,436 Can I have an arrow here? Okay. So 5,436 patients were there, with DES in 3 years with 3,545. We excluded, as I told you, taxes observed, 109 were excluded. As you can see, there is nearly 99 to 98.5 to 99% follow-up of both the groups. We ended up with 1856 Indian stents and about 1,539 imported stents. The follow-up is 99%. And as I will mention to you later, we did a propensity score matching to adjust for the selection bias, and we were left with 1,310 patients in each group. As you can see in the raw data, without adjustment, there is significant difference in the age, even gender difference, ejection fraction, whether you did primary or elective angioplasty, whether the patient clinical presentation is ACS or stable angina, even in the risk factors. Typically, Indian regulating stent patients tended to be younger, poorer, more often smokers, more often presenting with acute coronary syndromes, and less often diabetics and lower ejection fraction. Whereas the patients who got imported stents often tended to be older, multivessel disease, diabetics, and more of chronic stable angina, and less of smoking, little higher age group. This is a typical demographic profile we see in our day-to-day practice. Low socioeconomic status patients tend to be younger and smokers and present with acute coronary syndromes. So here you see all the baseline characters, there is a difference. You see the stent usage, you must be knowing we are biased towards using the Relicis stents. The Release-R stent or Relicis stent is about 76%, Yukon Choice about 12%, Biomime 5%, Abluminous 5%, Pristine about 1.2% and Premier 0.4%. Among the imported stents, again there is a preference seems to be for Promus family about 67%, Zynes family 16.5%, Endeavour 7.4% and Biomatrix 8.7%. We adjusted for the covariates including age, gender, whether it's primary or elective, ACS or stable angina, with risk factors and LAD is involved or not. So many factors we adjusted, and this is the propensity score matching before and after. I will not go into statistics. This is a method to correct for the risk factors. So after doing this, as you can see the baseline, we have excluded nearly 500 of the Indian stents and about 200 and odd of the imported stents. We are left with 1310 matched pairs. That means the patients are matched for most of the characters, all the risk factors and all the variables we gave. So you are seeing the rightmost column, there is no difference in the imported stent group versus the Indian stent group. So it almost resembles a randomized control trial. After adjusting for these risk factors, after the propensity score matching, there is not much difference in the proportion of the stents in both the imported and Indian stent group. Now, I wanted to concentrate the event rates of the various stents, as you can see, between the various stents, Abluminous, Biomime, Release-R, Yukon, Biomatrix, Endeavour, Promus and Zynes family, they are more or less same, from 1.5 to 6%, but the Abluminous only 64 stents are there. So when you look at the statistically, there is not much of significance. You can see the various endpoints, the total MACE. Total events in the Indian stents is about 59, and imported stents is 54 out of 1,310 patients. The various MACE, including in-hospital deaths, post-discharge deaths, subacute thrombus and target vessel revascularization, there is not much of difference in the both groups. Here you can see the odds ratio. You can see the Indian stents and imported stents. The odds ratio is always, the confidence intervals are always crossing 1, the median 1. That means there is no statistical significant difference between either the Indian or imported stents in any of the events, including total deaths, in-hospital deaths, or target vessel revascularization or SAT. The in-hospital deaths are slightly more, numerically more in the Indian group, but not statistically significant, probably because still whatever exclusion you do, the patients, the poorer patients come with acute coronary syndrome, and in-hospital death is seldom because of the stent that you implant. It is basically reflects the patient's illness, sickness. So this is the acute coronary syndrome patients seem to have slightly higher mortality when they had with imported Indian stents. As I mentioned, they are more of in-hospital deaths than the post-discharge events. And if you see again that target vessel revascularization more in imported stents, less in Indian stents, probably again the Indian patients who got Indian stents may not be going for affording a target vessel revascularization. Both the patient and doctor probably tend to manage it medically. And also more number of patients with Indian stents presented with acute coronary syndrome, so they tend to have some infarcted muscle, and the target vessel revascularization may not occur very frequently in them because they may not have viable myocardium so much. So because the most common stent was Release-R, we compared with other stents and the various groups. Again, you can see the forest plot on the extreme right. The confidence intervals are crossing 1, which means that there is no statistical significant difference when we compared the Release-R with various kinds of stents. So what are the limitations? It's not only observational study. I have grouped all the DES together because they are only in the each family. Most of them are shown to be equal. For example, biometric study, leader study showed it's equal to everolimus stents. Then there is a lot, Jotolimus stents are proven equal to everolimus stents, and Promus and Zynes are to start with same platform and same stents. And with each iteration there is a change in the design or metal properties or the length or some physical properties, but the more on in each family also we assume that both are of the long-term clinical efficacy is same. Follow-up is only 1 year, that's how most of the studies are done. Deaths and SAT are not educated, but we have taken care of that. SATs could have been higher, but it would reflect in the deaths. Drug compliance, we are not sure, but anything, the Indian stent patients tend to be less compliant with drugs. Standard of care may not be uniform, but the real world situation it is like that. Angiographic follow-up data is not mandatory on the 2 slides. Very high proportion of ACS and STEMI patients is a fact in Indian patients. As the society advances, the chronic stable angina increases and acute coronary syndrome patients decrease. So this typically reflects what is happening in the society, and higher death rate I explained maybe because of the sickness of the patients, and I already commented about the lower rates of TVR. So in conclusion, 1 year event rates in general are low and comparable with published results. There is no statistically significant difference in the combined adverse event points at the end of 1 year between Indian stents and imported stents. Higher death rate and lower TVR are due to high proportion of ACS and STEMI patients. Finally, Indian stents are comparable to Indian stents, and cardiologists need not hesitate to use an Indian stent. Thank you.
The data are quite encouraging for the Indian stents, no doubt about it. If there are any more questions for it, we can move out further.
The Sri Krishna Memorial Young Investigator Award.
I invite Dr. Ramesh Garu, Chairperson, and Dr. Sridhar Kasturi Garu onto the dais.
Let me introduce our chairperson today, Dr. Ramesh, who is presently working as a professor and head of the department of Gastroenterology, Usmania Medical College. He is a very close friend of mine, and now presently is working as a member of Medical Council of India. So I told him to attend this one as a guest, as a chairperson. So now we have a very important topic which is relevant to our day-to-day practice. Now I request our ethics committee, like a MCA ethics committee chairman, Dr. Ramakrishna Reddy Garu. He is not only physician, he is the first cardiologist. He has a vast cardiology practice also. I am very much privileged and honored to invite him. Sir, you are most welcome to deliver the lecture. The topic what I gave, what we expect from practitioners. So actually if you medical legal cases are going on, so that is the reason I asked sir to address the gathering. Thank you.
I feel very happy, and at the outset let me thank my friend Dr. Takayasu Rao. We were the other day for talking about the profession. He invited me that why don't you come and address this thing CSI. So it's all Kasturi Sridhar is also my family. I won't say that he's my junior doctor or anything. He's our family member. So he has been the chairman of this CSI, and he was also kind enough to invite me to this. And I thank the organizers for inviting me to this important conference. I here see most of the intellectuals only, but unfortunately now the audience is less. Probably you are now tired about all this, or probably then you thought that the medical, this thing, ethics is less important. It is a less important subject what you think, and less focused also in the profession. And you are all intellectuals, highly trained and important people. But what I have now seen, you know more and more and more about the lesser subjects. And then in the most important subject today, what we are seeing and facing in the society is the medical ethics. Day in and day out, the umpteen complaints are coming to the council on the ethics aspect of the medical profession, the negligence, the misconduct, and then all the disciplinary actions and all. So for that, you must all be aware that the things are not the same as it was in the past. In our days, even the medical registrations also were not that important. The other day, we got the latest information from the medical council. A doctor, very famous doctor in Bombay, with 20-30 years of experience, I was told he's the leading orthopedic surgeon. He has been debarred for life from practice just because he has no registration at all. I don't know how many of you have got the registration. MBBS is a must. Post-graduation is a must. And also super specialty is a must. When you are all claiming that we are all super specialists, yeah, we don't again contradict or deny that what you are claiming. But unfortunately, you are not at all getting registered. We see so many times intensivists, IC units, there the doctors who are handling this high intensive care, none of the people are rather qualified, number one, nor they are registered. When if they come to us, to the council, what is your qualification? Well, they are not supporting that. Second thing is, even if they have the qualification to claim that he is a specialist, he has no registration at all. Then how the hospital defends, how you yourself defend. So it is becoming a very irksome affair, and then sometimes a delivery. On one side we see they are all our youngsters, they are all our colleagues. The other side, the patient is so rather aggressive that we are trying to shield our profession. So we are now in a caught of a dilemma of then a conflict of interest again, as of Shastri. It cannot be a conflict of interest, but it is. In the real sense, it is a conflict of interest. We have to do justice. So with this brief introduction, I would like to ask, all of you please get registered. Second thing is, not only is the registration, this is valid only for 5 years. You do not know that it is only valid for 5 years. After 5 years, you have to revalidate your registration. And how do you get it revalidated? Earlier, they used to get for a refresher course and all that thing, but now the Medical Council has introduced a program called, this is an upgradation program. You have to earn the credit points. For example, a conference like this, when you are attending, if it's a 2 days conference, 2 plus 4, and if it is a 3 days conference, 3 into 2, 6, like that, if it's only 1 day's program like that, over a period of 5 years, you have to earn about 30 credit points. When you get 30 credit points only, you will be again, your registration will be renewed. Second thing, the qualification. Sometimes, you may be trained, you may be the best of the lot, but that is not going to support you. It has to be substantiated by a qualified degree which is registered with the Medical Council of India. I see the cardiologists also, diploma in cardiology. We have not seen the Medical Council, we checked up again. It is not being recognized, not being registered. But I see so many places, the diploma in cardiology, all the reports also we are seeing. You will be in trouble, and if somebody raises a question like that, I just want to make you know about this particular point. You may sometimes, yes, I am trained in, you say I am a so-and-so, I am practicing cardiology, I have got a training in cardiology, but don't claim a degree like that. So is the case, sometimes the physician comes, I am a diabetologist, I am a hypertension. You can say that, I have got an experience, but there is nothing like a diabetologist, there is nothing like a hypertension specialist like that. These are all small advertisements. It comes under the category of the advertisements, which I'll come to later. So coming to now the real subject of it, I have taken the summary points of this Medical Council, updated. I think I have circulated some of these copies to you, and if any of you do not get it, you can download from the Medical Council of India, the website. But for your convenience, I have also distributed some copies. Now coming to the subject, and let me thank Dr. Kasturi and Dr. Dayasaga for giving me this opportunity. My sincere thanks to Dr. Dayasaga Rao and Dr. Kasturi for inviting me to speak on this less focused subject of medical ethics in practice. I feel small and humble to speak before senior, learned and experienced Professor Vai. I was seeing Somaraju and other few friends, but they are now, I think, probably tired, they've gone away. With 5.5 decades of service in the profession as a senior physician, practicing all specialties, I humbly express my experiences and my impressions here. We have to consider every patient as a worried human being concerned about the disease and health, and our primary focus should be humanitarian consideration. This is lacking in most of our doctors. I am very sorry to say that. And we have to deal them with compassion, empathy, and concern. We should be communicative. And then again, this is a very important point. You never speak to a patient. We have to be communicative with these basic professional principles, and these communicative skills are not learned by going to the college or anywhere. They are learned by practice rather than reading a book. Next. When the doctor listens patiently to the complaints and explains the diagnosis, kindness and empathy helps the patient to express to you without fear and reservation. Being a specialist in cardiology, you must be decent in upholding the dignity and respect of referring doctors, your colleagues and physicians, and should refrain from criticizing. Most of the time, what does that fellow know, this fellow? So these are all very, 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 very rather unhappy experience you will be hearing. And the loose comments undermining your own colleagues. For a good doctor-patient relationship is must, and for that you have to be very polite, sympathetic and kind. Never to say abruptly, supposing somebody comes, in the terminal stage and all, do not speak at all. Never to say abruptly, there is no cure, as this may cause severe misunderstanding, a lot of, again, flare-up of emotions. Interviews with the patient most of the time, who have filed legal suits against the doctors, often cite, what is the reason here? The pure communication, lack of empathy and respect and rough behavior as the main grievance. Healing touch is very important. It protects us from many unseen future problems and also makes a doctor-patient relationship strong. Always obtain consent from the patient and his close family members. We should be equally polite, kind to the patient and his relatives. And what the pearls of communication, simple they are, but always give these communicating principles are always give patients and his relatives option for a second opinion. I am the last in the world. No, there is nothing like that. You will never be the last. So keep in touch with the family physician and also involve him in the patient care. The family physicians are very important, but this particular family is now that it's being not being seen at all, not being respected, not being valued by our own profession. Then Keep in touch with the family physician. I said never to be harsh with the patient or his relatives. What is a breach of confidence? Patient should feel that you are like his family member. Patient feel you are like God if you save somebody's life, and it displays trust and feels hurt when there is a breach of confidence and trust. And the role of a family physician, it's very, very immense as he plays a bridge between the specialist and the patient. And what are the patient's rights? Patient has a right to seek information regarding benefits, risks, and cost of treatment. And he also got a right to ask for the copies of the medical records, accepting or denying the decision suggested by procedures, and unwittingly they are earning the label of being labeled as the laboratory-oriented doctor rather than being addressed as a clinician. We are giving greater importance to emergency medicine and ignoring the preventive medicine, although we know that it is very important and most cost-effective. My suggestion to you, the cardiology gathering here, and your organization can do something. The needs of the society are to be looked after by providing good, healthier professionals to be available, affordable, amicable, and knowledgeable. Seniors should play as role models so that they can be an inspiration to the profession. And my small message, my take-home message is, maintain congenial, reassuring environment, be patient and calm, elicit the history carefully, listen with compassion and concern, make thorough physical examination in a methodical way, always make a provisional diagnosis, and refer for guidance and re-examine the patient more number of times because it's cost effective, and to find out the missing links since it's more cost effective, and ask for only the necessary investigations to help and confirm the diagnosis. Do not hesitate to take a second opinion. Explain to the patient the probable diagnosis and the treatment plan and also the details. Next. Come. Always obtain the written consent of the treatment and family. Record the findings clearly. Remember our commitment, cure may not be, harm never we should, but we can always try to help. And should show empathy in day-to-day handling of patients, especially in the serious situations. Lastly, avoid unpleasantness while charging the fees. This is very, very important. Avoid unpleasantness while charging fee for service. Most often, examples of incidences of clashes, rifts, disputes, fight, these are emanating from the payment of the bills, leading to quarrels, complaints in the consumer forums and human rights, and to the police, and also the complaints to the medical council, and as malpractice and misconduct defaults. Lastly, empathetic, transparent communication and good record keeping are the best insurance against malpractice suits. With good ethics, we are priceless, and without it, we are worthless. I hope you agree. And then here, an apt sloka from Gita. I feel rather very, very sensitive to quote that sloka in the 3rd chapter of Gita in the Karma Yoga. Yat acharati srestha tat tada iva itaro jana sa yat pramanam kurite tada anuvartate lokan. Here the meaning of this, you are all pandits. You are all pandits. Srestha means panditulu, pujulu, peddavaru, adarsineyulu, villandaru. So in the profession, all the professors are pandits. All the juniors are your students. So naturally, when the pandit is going on the right path, student is definitely adopting. And in our own language, day-to-day practice, yadha guru, tada shishya. And so also in the colloquial way, talitur pilla. So these are all, aptly stated in this particular sloka. If we conduct ourselves in the most rather sincere way, in an exemplary way, juniors are naturally, they will definitely follow us. Next. So I have spoken all the summary points in the contained in the rather regulations of the medical council that I will run through, but I have spoken salient features of the Medical Council of India for the benefit of my friends and also my juniors. I run through the current regulations of MSAIB, which all of you have to remember in the day-to-day practice, which is assuming very, very great importance in the light of many litigations and complaints on the doctors with reference to ethics and misconduct and negligence. I brought some copies, that I have circulated. Anyway, if you are interested, you can download and then, run through fast, some of the salient features, especially in the chapter 6, chapter 7, chapter 8. It deals with the conduct and negligence and also the punishments. And lately, probably, we say we're all, taking the all the sponsors, we are taking their benefits and all, but that also the government is trying to just put their iron iron hand on our dealings. We are not supposed to take the facilities from these companies and all. We are taking the travel facilities, some of the benefits also, some of the cash gifts, all those punishments also are delineated there. Probably you can go through. And then, here, before I say some of my practical prior cases, what we have come across in our society regarding our cardiology also. I have not seen any of your, with my vast experience, I don't know whether you have forgotten the taking of the history and noting of the findings. I rarely see any of your cardiologist notes anywhere in any area. Maybe in the institution, but in the private practice also, I hardly see any of the notes. Recently, I saw one patient, he has gone on an angiogram. Then I asked the gentleman, where are your notes? What is the pre-evaluation notes? What evaluation notes you want? What was the previous record? What was he? Why did he come to you at all? What for he has come? Why you have planning for an angiography and all? He was sorry to say anything. Whereas in one place we have seen that, there is a 220 blood pressure, 110 blood pressure. Then immediately ask, what is this 210 as a layman? Though I may be a senior doctor or anything, but to know I will be scared to do anything procedure unless there is a very, very urgent issue. And then there was no answer for me. Okay, after the angiogram is done, what is the event? Without even seeing the patient has been sent, are able to punish, nor able to save. So this is the dilemmas we are getting. Therefore, my request to you, all of you, is again be methodical. You should not. And I will quote the incidents where, if you feel like listening, I quote Dr. Ramurthy, the famous neurosurgeon. All of you know he has been a doyen in the neurosurgery. So one patient from North India. She took an appointment with great difficulty. She got an appointment after 3-4 months. She went to Madras all the way, and she went there to him with a big file. And then, he opened the file, and so wonderful. You are seen by Dr. Kasturi. He is my great student. He is a gold medalist. He has done a wonderful job. I'm sorry, just taking the incidents. So like that, he has been quoting the student. All are his students only. Most of the neurosurgeons all over India was students. Oh, this is another wonderful student. He has also done a wonderful job. I don't think I will be able to do anything better. So I think you can continue like that. So after he clinic, the doctor closed the clinic at 2:30 or 3 o'clock. And then as he was coming out, the patient was sitting there in the waiting room. What is the matter? I was the first patient. You are the first patient. I finished then and there only. Why is it waiting? Doctor, I am very much disappointed with you. I want to talk to you. Then he felt very sorry. What is the matter? Come on, please come. Then I thought, I came all the way. I thought you will touch me. You will examine me. You will ask me if I had told you that the file does not belong to me. Who is the message you are conducting? I am sorry, doctor. I never thought that without examining you will give the opinion. Then what is the revelation he made. I did not become angry. I bowed my head, hanged it in shame, and then I felt very sorry. I apologized to 10 times. I will again examine you fresh. And I took 1.5 hours examination methodically. From henceforth, I will never examine anybody, I will never see anybody's file. I will only examine the patient. Today, are we very much advanced to forget our systems? And that Somaraj was telling the other day, I believe some students from different places, how to auscultate. Why? There is no need at all for auscultation. Stethoscope is only to hang around the neck. It is no longer used at all. I am very sorry. This is happening. Like that I can quote any number of, the incidences. It is very, 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 very rather denigrating ourselves only. And then we want to run, please run fast. And some of the salient features, we can talk about. Only 6th and 7th, go up to 6th. Character is being talked, and then how to deal with the patient is talked, and how you have to interact with your own colleagues. You don't undermine the colleagues, sir. And supposing a colleague comes, don't charge the fees. That was there, our dictum there. But today you are charging the fees, the colleagues also. These are all the forgotten days. And the duties of physicians, the public. And then the chapter 6, unethical acts. A physician shall not aid or abet or commit any of the following acts which shall be construed as unethical. I have covered most of the summary. This is important. Soliciting of patients directly, indirectly by a physician, by a group of physicians, or by institutions or organization is unethical. A physician shall not make use of him or her name as subject of any form of manner advertising or publicly. And another thing, is important as you are dealing there. Big boards you are writing, that is not permitted. And some of the people are also putting their photographs on the files. That is a very, very degrading type of an action there. And then so I am a big specialist and all. If you got an award, you can say I am an awardee. But not in the registration. Not in the, you can only write your degree, suffix your degree. And if you want to write the training also, I am trained in this particular subject. I am the only the authority in the subject and all that thing. These are all pure advertisement. Name board also, and your prescription pads also should contain only the name and the degree, nothing else. And then charging of the fees or some more of the details are there. And come on. And last is the human rights is there. Euthanasia nowadays, we are not permitted any euthanasia. Go to the 7th. There are all in the columns where the endorsements and all those things are not permitted. The misconduct, keep it misconduct. Following acts of commission, omission on the part of the physician shall constitute professional misconduct, rendering him or her liable for disciplinary action. Violations of the rules. If he or commits any violation of this regulation, if he does not maintain a medical, record or his or her indoor patient for a period of 3 years as per the regulation and refuses to provide the same within 72 hours, the patient or his authorized representative makes a request for it. This is again a violation. Adultery. This need not have to dilate. Then the conviction in the court, I need not have to speak. Sex determination is not permissible. Signing of the professional certificates, where it is not permitted, that is again, come on, change. Run. And the punishment and disciplinary action, you will understand, there is no meaning again talking about the punishments, etc. Punishment.
4 ways of punishing a doctor. See, if a government doctor doing, he may lose the job, first one. Second thing is the medical council. So it go to an extent of permanent removal from the register, and that will be widely publicized in all the both print and electronic media. That is permanent registration loss. And the third component is consumer fora. The consumer fora depends upon the amount they want. So 20 lakhs to the state district forum, 1 crore to National Commission, anything above, 20 district, 1 crore up to State Commission, anything above 1 crore National Commission. The last but not the least is the criminal. So a criminal case any point of time can be booked. So right now, as far as the Indian history goes, there is the highest compensation paid to an NRI, about 11.43 crores has been awarded by the Honorable Supreme Court. So taking this into account, I request all of you see that your case sheet should be written properly, and more importantly, the documentation. Documentation should not be any communication gap. So every day it's a difficult day for us. So all days are not same to us. So don't leave anything on your juniors that he is going to write the case sheet and all that. So this I would like to close the session. Any doubts, please you can ask.
happened. One patient underwent a treadmill and everything. All tests were done in one diagnosis center. Treadmill, he has done extremely good exercise, almost 9 meds, negative. Then next day morning, one of my, Ravi, he's like a Abbott company. That guy works as an architect to his house. So what happened, next day morning he had a severe pain. When severe pain is there, normally if somebody calls, definitely what we say, it may be STT, because treadmill normal, echo normal, all tests were done. When patient had a pain, immediately I said, don't wait, you come to the hospital. When patient came to the hospital, extensive heart attack. Suppose the first person says, this is normal, this is 98% of the time, all cardiologists they do. So sometimes block can rupture, it can happen, coincidental MIs can happen. So if this happens, if that person says that, doctor, you said everything is normal, but it went differently, like I developed a heart attack, you said normal. So these times, sometimes have malintention.
No, see that these things, we are, any ordinary man, see the doctor's efficiency is judged by the highest man you don't compare. The lowest man, what he has done, much better than what he has done that. Reasonably laid down, scientific way is done. Is the rest of things, it is not in his making. And then these events are very common. Rustum Jan Vakil, the greatest cardiologist of our country, is just, after he finished a lecture, he went home and he was sitting, he was rather relaxing and he died like that. So like that, nobody, himself being a cardiologist, this nobody can predict. And also J.D. Birla in the Mayo's clinic, they have completed the examination, everything was wonderful, and he goes periodically for review checkup and all that thing. As he was coming out of the gate, he died in the car.
No, as far as this is concerned, I think it's not an issue at all, because Sridhar says he already advised the patient to stay back. He did not listen to him. That has to be documented in the
That documentation is very important.
No, this was done outside, somebody else.
Okay.
But when he...
The only what happens is, when try to contradict, that fellow had done wrong and I have done right, and then he should have done like, then this sort of unnecessary, suspicious, rather, doubts, creation of the doubts causes a conflict.
The other point is everybody is coming with a record. See, mobile phone is for recording. So they can record whatever you are talking without your knowledge. And error of judgment is always there for any consultant. So that can be taken care of by counsels. It's not a problem.
Thank you so much for the wonderful session, and we are moving to the next session, which is Sri Krishna Memorial Young Investigator Award. And for this I would like to invite the chairpersons to the stage. First of all, I would like to invite Dr. K. Narsaraj Garu, Dr. B.K. Sastri Garu, and also Dr. N. Ramakumari Garu to come onto the stage.
Good evening. Morning మొదలు వచ్చారు, ఈవినింగ్ అయిపోయింది. ఏమో నలుగురిలో ఇక్కడే ఉన్నాయి.
దీనికోసం నేను చాలా వర్కౌట్ చేస్తాను సార్. 1 వీక్ నుంచి రెస్ట్ లేదు.
దేనికి మీరా?
కాన్ఫరెన్స్ కోసం.
మీరా?
అన్ని సెషన్స్ అన్ని.
ఎవరైనా సార్ ఇంక్లూడింగ్ శ్రీధర్ కస్టడీ. హ్యావ్ యూ ఎవర్ స్పోకెన్ టు ఎనీబడి ఎల్స్ హూ ఆర్గనైజ్ మీటింగ్స్ బిఫోర్? హ్యావ్ యూ టేకెన్ ఇన్స్ట్రక్షన్స్? వాళ్ళకి మీటింగ్ అంటే seminar చేసినట్టు please don't get offended.
We don't have any experience.
There should be a time for discussion.
The first case, sir, we are giving the list to you. Amit Baradia first.
We don't have any experience at first, basically.
మాట ఒక రోజు చిన్న మీటింగ్ ఫిట్ చేసి how do you think we should proceed? What are the timings? What are the topics? What are the kind of
Next time.
Good afternoon, respected teachers, chairpersons and all delegates. We all know the contemporary guidelines recommend the use...
Doctor, excuse me, I'm here. I think even time is also important component of presentation. So if you exceed time, that will be negative.
Okay.
So make sure that that's part of the competition.
And time
Okay.
we should give 10 minutes.
What is the time? 10 minutes?
10 minutes.
How many of you are there exactly? 8 minutes. How many speaker presentation?
So,
Five speakers.
8 minutes and 2 hours questions.
Yeah.
2 minutes questions.
Okay. 8 minutes presentation, 2 minutes questions. Okay, go ahead.
We all know that the contemporary guidelines stress on the usage of radial access as the standard of care, which inherently requires us to reduce the potential disadvantages associated with transfemoral access. So in order to further reduce the dependence on the transfemoral access, we decided to compare the transulnar access for testing the efficacy, ease of access and also the safety of outcomes. So we designed this study with the primary objectives of the successful arterial access, then the ease of access in the form of access time and procedure time, fluoro time, and then the immediate outcomes in the form of access related complications. We also did have secondary objectives in the form of assessing the incidence of ulnar nerve injury clinically and also the incidence of ulnar artery occlusions. We did this follow-up at the 1 month after the index procedure. So the methodology, this study was conducted at Apollo Hospital. It was a randomized prospective study and it was done over a period of 2 years and the sample size was around 205 patients. The inclusion criteria were in all the patients with clinical ECG or imaging evidence of CAD and who were scheduled to undergo coronary angiogram provided they were more than 18 years of age and patients who gave an informed written consent. The exclusion criteria were those who presented with cardiogenic shock or Phillips class 3 or 4, those who were patients of chronic hemodialysis and who were status post CABG. Obviously, those who were not less than 18 years or didn't give consent. So what we did was we randomized 205 patients before examining the radial or ulnar artery. Then after randomization, what we did was we did the classic Allen stents for those who were randomized to radial access and the inverse Allens for those who were randomized to ulnar access in order to check the suitability of the randomized access. Then after randomization, we went ahead with the procedure and those who required crossover, the default crossover strategy was transfemoral as the ipsilateral crossover is not recommended by the previous studies. So the default access for crossover for both the arms was transfemoral. And those who had to undergo crossover, those were excluded from the further analysis. So the baseline characteristics, the mean age was around 53 years in both the groups. The study included around 43% of women in both the groups, which is in accordance with the ICMR guidelines of including at least 30% of females. Then the baseline comorbids were similar in both the groups, no much difference, and reflected the everyday practice of the most common risk factors seen in the form of diabetes and hypertension. The presenting complaint to get evaluated further was mostly the complaint of chest pain in both the groups. And in this study, the majority of population belonged to the ACS group in both the subsets. So this study again would give us an idea about the use of transulnar access in ACS patients also, where the transradial is the recommended route. Now the procedural success, which was predefined as successful cannulation of the sheath, was around 96% in the transradial arm and 87% in the transulnar arm, and the crossover rate seen was very high in the transulnar arm, around 30%.